Hello everybody. Today we are going to discuss about traumatic brain injury. So the injury from traumatic brain injuries commonly is divided into two subtypes. Primary injury is dealt with the deal directly to the brain by initial insult and can be modified only by prevention. So much of the pre-hospital emergency department and ICU care has long been targeted at reducing secondary injury, which affects up to 91% of traumatic brain injury patients. Like hypotension, secondary injuries like hypotension, hypoxia, hemorrhage, intracranial hypertension, cerebral edema, seizures, metabolic derangement, this all contribute to the secondary injury. So, regarding diagnosis, the mainstay of the urgent neuroimaging remains computed tomography. Although magnetic resonance imaging is the more sensitive for axonal injury, small hemorrhage, acute ischemia, and visualization of the brainstem and posterior fossa structure. CT is rapid, readily available, and more sensitive for acute SAH and readily show large hemorrhage and large subacute infarct. CT angiography and less commonly CT venography are also utilized to investigate suspected concomitant vascular injury, and CT scanning is also done in the context of polytrauma to visualize extracranial injuries in the chest, abdomen, and pelvis. Now, regarding blood pressure target, systolic blood pressure is maintained over 100 mmHg for those with age group of 50 to 69 years, over 110 mmHg for those with 15 to 49 years, and over 70 years, and management to maintain the adequate cerebral perfusion pressure improves the outcome. Although some guidelines utilizes the systolic blood pressure goal using mean arterial pressure facilitates the computation of CPP when ICP measurements are available that may be more important than SPP alone. Corticosteroids are contraindicated for the management of the brain edema related to traumatic brain injury because they are associated with worse outcome. Now, regarding fluids in the traumatic brain injury, isotonic fluid remains the primary vehicle for volume resuscitation. Studies of hypertonic saline as the resuscitation fluid have been equivocal. 7.5% saline solution and 500 ml osmol per liter sodium lactate showed improved outcome, while a study using 7% saline solution reveals the no benefit. So, hyponatremic and hypoosmolar fluid induces the extracerebral edema and should be avoided during resuscitation and throughout the critical care phase of traumatic brain injury, even when hypernatremia is present. 5% dextrose as the resuscitation fluid for non-brain injured children has been associated with evolution of cerebral edema. A rat model of traumatic brain injury comparing ringal lactate and 5% dextrose infusion reported significantly increased mortality for animal treated with 5% dextrose. Aside from avoidance of hypotonic fluid, concern surrounds the metabolic derangement that inevitably occurs in patients who received intravenous fluid resuscitation and osmotherapy with development of hypernatremia and hyperfluoridemia. Initial studies investigating the impact of these on outcome of traumatic brain injury patient found correlation of hyperchloremia but not hypernatremia with mortality. Subsequent studies have been done investigating the use of lower chloride containing fluids such as sodium acetate and found to have an equivocal hemodynamic profile with normalization of hyperchloremia and metabolic acidosis. So the next is mannitol, which is 1 gram per kg IV is the first choice for measured and the presumed ICP elevation. Preoperative high dose mannitol, that is 1.4 gram per kg IV, benefits patient requiring emergent surgery for subdural and temporal lobe hematoma. Mannitol is infused through 5 microgram filter and must not be infused through full catheter, such as those used for targeted temperature management, owing to the risk of precipitation of mannitol out of the solution. Hypertonic saline solution, including 23.4% saline, may be used in place of mannitol during trauma resuscitation and may be a slightly more sustained effect and improve outcome. The advantage favoring hypertonic saline is that it acts as volume expander, where mannitol acts as osmotic diuretic, possibly reducing the effectiveness of volume resuscitation, and if not used judiciously, can result in complications from hypervolume such as renal failure, electrolyte abnormalities, and rarely pulmonary edema. However, 23.4% saline solution must be infused through central venous catheter. So seizure may increase ICP and may lead to secondary injury. So prophylaxis during first 7 days after severe injury is standard of care. Though this has not been shown to alter long-term mortality or even the incidence of long-term epilepsy. Phenytoin is the common choice as it is available in the enteral in IV formulation. Levetiracetam is the popular because of its low incidence of interaction. Neither has been shown to be superior to the other. Although it is often favored for its side effect profile and limited drug interaction, levetiracetam can also cause aggressive behavior and contribute to agitation that complicates management in the ICU. For patients who exhibit this problem, the author will use valproic acid that has a mood stabilizing effect, and for selected patients with sympathetic spanning, use propanadol provided it does not cause systemic hypertension. Now, regarding reversal of anticoagulation must be performed for traumatic brain injury patient with ICH. Among patients receiving vitamin K antagonist with INR over 1.4, vitamin K 10 mg IV should be given, followed on day 2 and day 3 by 5 to 10 mg enteral. Reversal of anticoagulation with 4-factor prothrombin complex concentrate dose by weight and the INR is faster than and superior to plasma transfusion. Kcentra is PCC, which is FDA approved for warfarin reversal among patients with major bleeding and requiring urgent surgery. For patients with history of heparin-induced thrombocytopenia in past 90 days, plasma transfusion and factor 7A dosing may be considered because Kcentra contains small amount of heparin. The anticoagulant effect of direct thrombin inhibitor, dabigatran, can be reversed by FDA-approved reversal agent, idarucizumab, which binds and inactivates dabigatran. If idarucizumab is not available, Kcentra, hemodialysis, and hemofiltration have been attempted. Adnexanet alpha is the chemical antidote to reverse direct factor 10A inhibitors such as apixaban, rivaroxaban, among others, and reverses anticoagulant effect of these drugs. However, the studies investigating its utility look primarily at 10A activity and hemostatic efficiency and only reported very limited clinical outcome data, leading many to conclude that further studies, trials with primary clinical outcomes are needed. Given the cost effectiveness concern and limited study, Kcentra has been recommended and is more used for this patient. For patients receiving aspirin, platelet transfusion may be considered for those requiring urgent neurosurgery. Transfusion is not as useful for patients receiving glycoprotein 2B3A inhibitors and that transfused platelets are inactivated, though salvage transfusion is often considered. A recent systematic review and meta-analysis of patients with traumatic intracranial hemorrhage who were taking antiplatelet medication looked at the effect of platelet transfusion and found no effect on mortality, hemorrhage expansion, or need for neurosurgical intervention, and concluded that current evidence does not support the use of platelet transfusion for this population of patients. Another study suggests the harm from both platelet transfusion and desmopressin treatment for this population. Now, regarding surgical therapies for traumatic brain injury, surgical hematoma evacuation is commonly performed acutely for subdural hematomas over 1 centimeter in width and epidural hematomas with significant mass effect or progression. Routine evacuation of parenchymal hemorrhage is not indicated as violation of otherwise healthy and recoverable tissue may be required to access the hematoma. Uh, However, intracranial hypertension refractory to medical management may be an indication for resection of parenchymal hematoma. Decompressive craniectomy has historically been viewed as last resort for management of traumatic brain injury with intracranial hypertension. One complication of decompressive craniectomy is the injury to the brain tissue blood vessels, especially vein, at the edges of craniectomy defect. The authors recommended removal of at least 12 centimeter of diameter bone flap and extension of craniectomy to temporal bone is also sometimes recommended. A retrospective review of TBI patient treated with decompressive craniotomy found no outcome benefit compared to a historical control. Analysis of non-randomized series of patient with GCA score less than or equal to 9 and midline shift greater than width of extraaxial hematoma were considered for decompressive surgery revealed that treated patient had worse GCS on admission, but more survived to discharge and more were discharged to home skilled nursing than those of non-surgical group. So, the often cited decompressive craniectomy in patients with severe traumatic brain injury, that is DECRA study, randomized patient prospectively to decompressive surgery or medical therapy. The study showed no difference in survival, but more patients with poor outcome. However, it was plagued by problems with randomization in that the treatment group had significantly more patients with unreactive pupils than medical group, and the study had intent to exclude the patient with unreactive pupil altogether. Comparing the ICP level of both the group also revealed that well-controlled ICPs for medical group as well as surgical group, raising the concern that this was not the appropriate cohort study to investigate the utility of this surgery. Similar results were seen in the rescue ICP trial, which allowed unilateral hemicraniotomy or bilateral decompressive craniotomy for refractory ICP crisis in traumatic brain injury patients. So, surgical decompressive craniotomy includes survival, but more survival in surgical group will depend on the other than medical group at 6 months as measured by GCS outcome scale. The current recommendation is to pursue shared decision making during this scenario with patient or surrogate because these surgical procedures do not reverse the significant brain injury that has already occurred. So this is the ICP measurement from DECRA trial showing the values from medical arm and surgical arm. Note that ICP values of medical arm are well controlled at 20 or less, and though the surgical arm has a lower value overall. All the ICP values of both the groups are well controlled, suggesting that these are not truly refractory ICP patients that we subject to decompressive surgery in first place. So, regarding neurological critical care, although the physical examination remains the gold standard for neurological monitoring, many patients with severe TBI require sedation and other therapies, which make surrogate monitoring mandatory. Although important for reduction of the duration of mechanical ventilation and the prevention of ventilator-associated pneumonia, interruption of sedation is contraindicated for patients with elevated IC. Elevated ICP, particularly when not responsive to therapy, is associated with worse outcome. A benchmark evidence from South American trial, a treatment of intracranial pressure, that is base strip trial, demonstrated no improvement of outcome with protocol-driven ICP over one guided by clinical observation. However, ICP monitoring remains the standard of care where available and it's supported by consequences statement. Anatomical and logical consideration influences the selection of EVD over parenchymal ICP monitor and vice versa. EVP have the advantage of offering the ability to decrease ICP by draining CSF and thus favored when feasible, especially when hydrocephalus is present. EEG is indicated when mental status is worse than anticipated given the known injuries, and continuous EEG is favored. Poor brain tissue oxygen tension is predictor of poor outcome, and treatment guided by brain tissue oximetry has been shown to improve outcome. So the brain oxygen optimization in severe traumatic brain injury, that is BOOST 2 trial, preliminary analysis suggests benefit with multimodal monitoring that include both ICP and regional oxygen monitors. Now, regarding treatment of elevated intracranial pressure, for all patients with elevated ICP, maintenance of intravascular volume is important because it improves the CPP. For patients with significant acidosis and those requiring high volume of crystalloid, the substitution of isonatremic sodium acetate for sodium chloride may limit the development of hyperchloremic metabolic acidosis. Adequate analgesia and anxiolysis can help maintain adequate acid. Head elevation to 30 degrees above horizontal decreases ICP without sacrificing cerebral perfusion or oxygenation. Regarding mannitol, mannitol has been known to lower ICP. Doses of 0.25 to 1.5 gram per kg IV commonly used every 3 to 8 hours. Acutely with rapid infusion, mannitol increases circulatory volume, blood pressure, cardiac output, and decrease the blood viscosity. This may lead to decrease in ICP via increase in cerebral blood flow and autoregulatory decrease in cerebral blood volume. Mannitol also acts as osmotic diuretic, recruiting water from interstitial space through blood-brain barrier, which is nearly impervious to the mannitol. Mannitol has been shown to preliminarily shrink the brain tissue where brain blood barrier is intact, though it has been shown that midline shift does not increase with mannitol use. Mannitol may leak into damaged tissue that has been shown to leave that tissue once it clears the bloodstream. Additionally, it does not accumulate to the concentration higher than those of plasma. Thus, no reverse gradient exists to exacerbate cerebral edema. Mannitol clearance from the bloodstream can be monitored by measuring osmotic gas. Now, regarding hypertonic saline may be used to decrease ICP like mannitol, and hypertonic saline has hemodynamic effect in addition to its osmotic effect on cerebral edema. The use of hypertonic saline at concentration varying from 3% infusion to 29.2% bolus has been shown to improve ICP, both as primary measure and when mannitol fails. Studies comparing the serial doses of mannitol to hypertonic saline demonstrated the equivalent efficacy in lowering ICP. The most recent systemic review and meta-analysis detected no superiority of one over other. Loss of efficacy of ICP control when hypertonic saline is used over several days' time may be due to narrowing of osmolar gap and formation of osmolyte as persistent hypernatremia frequently develops. The relationship between hypernatremia, renal function, and outcome is complex. Only one study has directly examined the relationship between varying level of hypernatremia and outcome. Though patients with more severe injuries were more likely to be hypernatremic, likely owing to more aggressive osmotherapy, there was independent association between finding serum sodium over 160 and mortality. Although it is well known that hypernatremia, the setting of hypovolemia, is associated with renal failure, the safety of euvolemic hypernatremia is not. It is known that a rapid decrease in serum sodium may lead to cerebral edema among the healthy patients. When significant hypernatremia develops among patients with cerebral edema, it may be safer to limit the treatment that increase the sodium level while resisting treatment that directly lower it. However, recent analysis has linked increased mortality to hyperchloremia rather than hypernatremia. Diabetes insipidus is the only sign among those with traumatic brain injury. And treatment with vasopressin to limit the free water diuresis may be safer way to combat hypernatremia in this setting than the parenteral free water administration. Now, the cerebral perfusion pressure and the Loon concept. In contrast to purely ICP-based management, the Loon concept describes the strategy for lowering ICP based partially on decreasing CP. In this strategy, it is postulated that increase of MAP may exacerbate cerebral edema, especially when large amount of crystallized solutions are administered. MAP is lower to decrease hydrostatic capillary pressure and ameliorate cerebral edema. Mannitol and vasopressors are generally avoided. CPP is tolerated as low as 50 mg. Multimodality monitoring, often including bedside microdialysis, is required to monitor metabolic reactivation of vulnerable tissue to decrease CPP. These concepts and clinical management need to be interpreted in the light of assessment of cerebral autoregulation or the lack, therefore, of including waveform analysis, dynamic serial assessment of response of the ICP to changes in the map. Now, regarding temperature management, hypothermia increases the body's metabolic demand. Hyperthermia increases the body's metabolic demand and worsens the cognitive impairment and has been associated with the worse outcome. So, induced hypothermia has been shown to improve neurological outcome after witnessed cardiac arrest. So, recent study after cardiac arrest suggests that targeted temperature of 36 degrees Celsius is effective as 33. However, this has not been studied for the traumatic brain injury. So, induced hypothermia has been shown to improve outcome using animal models. So, the first hour after injury was found to be critical. A series of large and multi-center trials, however, failed to show the benefit of prophylactically induced hypothermia after traumatic brain injury. Still, class 1 evidence shows that induced hypothermia lowers the ICP. And side effects include hyperglycemia, immunosuppression, hypovolemia, electrolyte imbalances, largely due to cold dialysis. Rapid rewarming or overshoot may lead to rebound intracranial hypertension and impaired cerebral vasoreactivity. Patient presenting with mild hypothermia after traumatic brain injury should not be aggressively rebound. Fever defined as core body temperature of 38 degrees Celsius, affecting up to 68% of traumatic brain injury patients within 72 hours of admission and is associated with worse outcome. Although much effort is spent in ICU to reduce fever and induction of hypothermia continues to be investigated, neither effort has been conclusively shown to improve outcome after TBI or may be harmful. A latest multicenter randomized trial from Europe of hypothermia for intracranial hypertension after TBI reported worse outcome for hypothermia group and was stopped for harm. Now, regarding induced coma, pharmacologically induced coma may be appropriate step taken when ICP and CCP cannot be managed by aforementioned means. Prophylactic administration of barbiturate does not improve outcome. The pentobarbital is most common agent reported for this purpose and is postulated to lower ICP by reducing cerebral metabolic rate and cerebral oxygen consumption. Pentobarbital has numerous side effects, including hypotension, cardiac depression, immune system suppression, and hypothermia. Close attention must be paid to maintain adequate hemodynamics. Coma is induced with the slow bolus of 5 to 10 mg per kg of pentobarbital, followed by the infusion of 1 to 3 mg per kg. Although many centers check the pentobarbital level, continuous EEG monitoring provides the more useful measure of dosage, with goal being the reduction of ICP to acceptable level and induction of burst suppression on EEG. Serum drug levels are of value when evaluating for CNS function. For example, when brain death is contemplated or clearance of drug from bloodstream must be confirmed. The best evidence for the utility of pentobarbital coma to date continues to be a small single-center study of 55 patients from 2010 that reports survival at discharge of 40% with good functional outcome in 68% of survival at 1 year and association of sodium more than 160 and serum osmolality of more than 330 with mortality. An additional challenge in using pentobarbital is its very long half-life, requiring prolonged stay in ICU during weaning process, which has been reported to be from 4 days to as long as 12 days or longer, waiting for patient to wake up, guided by continuous EG monitoring, drug level, if present, examination finding. There is also need to be explicit avoidance of prognostication based on neurological assessment while the drug is still in patient system, as pentobarbital can suppress all brain function, including brainstem reflexes, and give false appearance that the patient is brain dead clinically. The propofol has been described as an agent for ICP control. When used to achieve burst suppression at 2 mg per kg of loading dose followed by infusion up to 200 microgram per kg per minute is required. Severe hypotension and propofol infusion syndrome are the adverse effect when using the high dose propofol. Now, systematic critical care, mechanical ventilation management, hypoxia, hypercarbia may exacerbate secondary injury and complicate ICP CCP management. So the Brain Trauma Foundation recommended maintaining the SpO2 over 90% and PO2 over 60 for traumatic brain injury patients. Advanced mode of mechanical ventilation and inotropic and vasopressor treatment are frequently required to maintain cerebral perfusion pressure and adequate gas exchange. For some patients, hypoxia may be resistant to conventional ventilatory setting, and increasing PEEP and fraction of inspired oxygenation may be required. Concern has been raised over the effect of PEEP on ICP. Published data, however, reveal varying effect of PEEP on ICP. One theory points that PEEP raise intrathoracic pressure, thus decreasing venous return to chest and increasing the volume of venous blood inside cranial wall, leading to increasing ICP. In reality, it is unclear to what extent change of the PEEP are transmitted into thoracic cavity, much less into vascular system, where venous return could be affected, especially among patients with acute respiratory distress syndrome, where stiffness of the deceased lung may not transmit the PEEP efficiently. A series of traumatic brain injury with acute lung injury and ARDS reported that ICP was more tightly associated with PCO2 than the level of PEEP. For refractory hypoxia, prone positioning has been reported. Although in some neurocritical care series, raised ICP have been reported, in dedicated series of traumatic brain injury patient with ARDS, prone position was associated with improved oxygenation without detrimental effect on ICP or CCP. So ventilation of the traumatic brain injury patient demands attention to systemic acid-base balance and secondary effect on the cerebral blood volume. Therapeutic hyperventilation is the fastest way to lower ICP, causing rapid vasoconstriction of cerebral arterial supply. Animal experiments and human observation reveal that hyperventilation causes decrease in partial pressure of oxygen in brain tissue, and hyperventilation is now contraindicated during acute phase of TBI and is discouraged by most of the authorities. So even for normal tissue, normal brain tissue, decrease of PCO2 below 30 resulted in decrease in cerebral blood flow and evidence of anaerobic metabolism. Although evidence of harm with less aggressive hyperventilation is lacking, evidence for its benefit is absent. This intervention cannot be recommended with enthusiasm. If used when other measures fail, hyperventilation should be monitored with one of the marker for tissue stress, such as brain tissue oximetry and microdialysis. Regarding glucose monitoring, in 2001 multicenter trial revealed that tight glycemic control improves outcome of critical care population. This finding led to the revolution of ICU glucose management, with many hospitals implementing ICU-based protocol targeting maximum serum glucose level from 110 to 1. So more recent trial have questioned this result and prominently the normoglycemia in intensive care evaluation and surviving using glucose algorithmic regulation, that is NICE trial, which reveal increased mortality of patient treated with tight control protocol targeting serum glucose under 108 compared to protocol targeting under 180. For traumatic brain injury and neurocritical care population, concern has been raised over glucose delivery to the region of vulnerable brain tissue, which may already at the risk of poor perfusion owing to cerebral edema. A study using microdialysis to examine glucose delivery revealed the significantly low brain glucose level associated with signs of metabolic stress among patients treated with tight glycemic control strategies. A meta-analysis concluded while blood sugar over 200 were likely harmful, over tight glycemic control was also harmful, and blood sugar target level under 180 was suggested. Regarding nutrition and metabolism, a thorough review of literature regarding energy expenditure of traumatic brain injury patients found that historically held belief regarding brain injury patients elevated metabolic rate and nutritional needs are valid. Moderately to severe injured traumatic brain injury patient exhibit metabolic rate of 96% to 132% of predicted baseline when sedated and 105% to 160% over base when awake. Another review documented same finding when hypermetabolism reached 20 to 200% of predicted baseline. A traumatic brain injury are also catabolic, exhibiting -3 to -16 gram per day nitrogen balance, and the resultant decrease of muscle mass and related immune function deficit may worsen outcome. Although the common practice is to prescribe nutrition targeted to exceed baseline predicted need by 40%, the author favored use of indirect calorimetry to better target each patient's individual need. Although upper GI tolerance is common early among those with traumatic brain injury, placing patient at risk of aspiration pneumonia, some studies do show trend to improve outcome with institution of early feeding. So no conclusive data exists to suggest favoring post-pyloric feeding to gastric feeding. Now, regarding the prevention of venous thromboembolism, pulmonary embolism is third leading cause of death among patients surviving pa pa past day one of traumatic brain injury. The trials comparing early to late chemoprophylaxis are lacking. Low molecular weight heparin is superior to the unfractionated weight heparin for prevention among patients with polytrauma spinal cord injury. The guidelines support the therapy with intermittent pneumatic compression system within 24 hours of admission and chemoprophylaxis with low molecular weight heparin and unfractionated weight heparin starting 24 to 48 hours after admission and completion of surgery as long as there is no evidence of continued bleeding. Thank you.